A minute or two. We're just going to give it a minute or two for everyone else to join and get their audio working before we officially start. All right. Well, in the essence of time, we'll go ahead and get started. Thank you, everyone, for joining us tonight for our very first nurse seminar. We are so excited to have Nikki and Jen from our Penn State Health Pediatric Trauma Team present on mild traumatic brain injury in the student population. Just a few housekeeping things. We do record these, so if you would like to rewatch it or just revisit it at any time, we will be placing the recording on the PASNAP website. And so you can refer to it then on that site. Also, if you have any questions or comments for Nikki and Jen throughout the presentation, we invite you to utilize either the Q&A or the chat box feature, and they will get to as many questions as time permits throughout the session. So again, thank you for being here today. And Nikki and Jen, I will go ahead and pass it over to you.
Great. Thank you guys so much for having us here. This is a subject matter we're excited to talk to you about. First, we'll just introduce ourselves. Nikki, would you like to go first?
Hi, I'm Nikki. I'm the pediatric trauma coordinator at Hershey. I've been in this position since June and been in the emergency department at Penn State Hershey for the last 12 years.
And I'm Jen, so I'm our pediatric trauma program manager. Prior to this role, I worked also in the ED for quite a long period of time. So between Nikki and I, we have combined 20, 30 years of pediatric emergency and trauma experience, and head injuries are definitely one of the things that we see the most when kids come in. So we're going to talk to you about some of those things. We can do next slide. Okay, so objectives today, we're going to first talk about what a concussion or a mild TBI is, traumatic brain injury, talk about some of the risk factors and common causes, signs and symptoms, things that you as school nurses can do to understand what those look like, when to seek emergency treatment, which is definitely important. What does it look like when kids get emergency or inpatient treatment, the tools to get them back to school, play, and learning, and definitely strategies to prevent injury. Next slide. Okay. And certainly if you guys have questions, if you have comments, we invite you to put those into the chat as we're going along. We love to interact, so feel free to ask any questions or give any feedback. So first of all, concussion or mild traumatic brain injury. First, it's worthwhile to note that a concussion is a mild traumatic brain injury. That's something that in the hospital world, we're really trying to get people to identify with. All too often, when people hear concussion, they say, it's just a concussion. It's not a major head injury, it's just a concussion. But make no mistake, a concussion is a mild traumatic brain injury. And that's something that takes time to recover from and should be taken seriously. So those two words are interchangeable, but we really try hard to make people understand that it is a mild traumatic brain injury. So what is that? Anytime that you have an injury from a mechanical force to the head, that's really a concussion. I think this video sums it up really well. It's from the CDC. And if you just want to push play, this is a good video to share.
Increased stress or injury until
you'll have to back it up to the beginning.
A type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
So I like that summary and the visual a lot. One of the things that's hard about concussion is it's not something that you can just do a test and it says, yes, this person has a concussion. When we get a CAT scan, we look for things like skull fractures, brain bleeds. We don't look for it to say definitively whether something is a concussion or not. A lot of times we diagnose concussions based on the symptoms, based on the mechanism. So that can be somewhat challenging. But yes, the brain gets bruised, it gets damaged, it takes a long time to heal. And the most important thing to know is someone who's had a concussion is very prone to being injured again. And what we worry about is a concussion on top of a concussion, because that makes it much, much worse. Nowadays, the field of sports is much more sensitive to it. It used to be way back when people had a concussion, they hit their head, they were sent right back in the field regardless. But people are starting to understand that repetitive concussions are very damaging. So we're seeing some things change that way. So further definitions. We talked about how a mild TBI, and you'll see it referred to in this deck as MTBI, so mild TBI, force or impact to the head or body. They sort of differentiate this by the injury, and you may have learned this back in nursing school, the coup and the contra coup. But essentially, when you have an injury on the side of the force, that's a coup injury. So you get hit in the head with a soccer ball. Soccer ball hits you right in the head. Maybe it hits you on the side. And if your brain is bruised underneath where that soccer ball hit, that's a coup injury because the brain is injured directly underneath. We see that a fair amount, but we also see contra coup quite a bit too. So let's say that something hits somebody in the head and your head moves sharply. Hello, Nikki. And then where the brain moves inside the skull, when your brain moves and smacks your skull on the other side, that's the opposite side of the impact, and that's a contra coup injury. Some more about pathophysiology. Essentially, there's a lot of stuff that goes on with the brain with the ionic, metabolic, physiologic events, and you have a lot of acute symptoms as a result. Next slide. So we've talked a little bit about concussions. We've said that they can be serious. Why are we particularly concerned with concussions or mild TBIs in children? Next slide. So kids have this trifecta of risk factors. Kids have one, they've got a developing brain. Two, they have a developing body. And three, just by nature, they are curious and they engage in risk-taking behaviors. So these three things together make them ripe for concussions and brain injuries. It's different than adults. With adults, our brain is as developed it's going to be. It just goes into atrophy after that. Our bodies are pretty well developed, and hopefully we've sort of moderated some of that risk-taking behavior as our frontal lobe becomes better developed and we make better choices. And we're going to talk about each of these three things in the next slides to come. Next slide. Okay, so developing brain. Kids, as they're growing, your brain is changing too. Your brain isn't fully developed and grown until you're really through the teenage years and really into the young 20s. And the younger you are, the less your brain is developed. So a couple things are pertinent when it comes to head injuries in kids. One, kids have less white matter as compared to adults. So what is white matter? Why do we care? White matter is what you need to exchange information across the brain. It's like the game of telephone. It communicates between different areas of the brain. And if you don't have enough white matter, it doesn't allow those areas of the brain to communicate and talk to each other. So when you have a concussion or a head injury, it's harder for your brain to send those signals and communicate. It makes it harder for kids to process things. I can tell you just as an anecdote, I remember my son, he had a pretty severe concussion when he was, I want to say around 5 years old. And I would ask him a question after he had a bad concussion, and he would just sort of stand there looking at me because it took him so much time to process because his brain just wasn't communicating to send that message. And that comes back to that white matter that's responsible for that communication. So that's one of the things we'll see. Two, they're still pruning or sort of eliminating the neuronal connections in the brain that you don't need. So there's some extra junk sometimes that gets pruned away and stripped away, and you got a little bit more junk like that when you're younger. All this is resulting in a kid being more susceptible to both chemical and metabolic changes in a mild TBI. They're way more sensitive to stress or additional injury until they're fully recovered. And Nikki will get more into that, but the biggest thing, one of the biggest take homes that we can tell you from this session is that kids who have head injuries really need to take a long time to recover, because one head injury alone is typically okay when it's just a mild TBI or just a concussion. You have supportive care, you can manage through it. But you must be hyper vigilant to make sure that you don't have additional head injuries, because every single injury that stacks on top of it makes the recovery harder, and makes more significant and serious injuries. And the last thing with the developing brain is the axons in the brain, they're not as well myelinated. So that's going to just predispose children to traumatic injury. So all those things together, this developing brain is a little more fragile and makes head injuries more common. So in the realm of trauma, Nikki and I take care of trauma patients all the time. Head injuries is one of the far biggest things that we see. And then this isn't listed on the slide, but the other thing is the younger the kid, the bigger their head is in relation to the body. We kind of lovingly refer to it as their big head, little body syndrome, because the kids kind of grow into that, but their heads are bigger, and that almost is like a projectile a lot of times, which does result in those head injuries. Next slide. Okay, so they also have a developing body, and primarily what this means is the musculature in their cervical and shoulder area, all these muscles around the neck, they're not strong enough. So when they do get into, whether it's a car accident, whether it's a sports injury, because these muscles in their neck and their cervical area aren't as strong, they're not able to support the force and the impact that happens. That causes the head to move back and forth with a greater speed, greater velocity, and greater force, which is more stress on the brain. And so because they don't have those strong muscles in their neck and across their back and up in their C-spine area, they don't have the ability to absorb that mechanical energy and spread it throughout their body. So when they've got that sort of weak muscles, weak neck, it's all head. Their head is moving tremendously a lot more than an adult or even an older teenager, so to speak, who has some better developed muscles up there. Next slide. Okay, and the third thing, which is inherently pediatric, inherently children. Kids are just curious by nature. They're more prone to risk-taking behavior. You're going to see kids doing things also that they need developmentally. We want to see kids going on swing sets, climbing trees, although as the trauma nurse, it does give me a little bit of heartburn to see kids in trees, but they want to explore the world around them. And because their brain isn't as developed, sometimes they make choices to explore that are a little more inherently dangerous than maybe they should have. So, you're going to see kids more often skateboarding, climbing, playing on playgrounds, and just being engaged in sports. So when you put all three of those things together, when you've got this developing brain, this body that really isn't strong and supportive enough to kind of dispel forces, and they're engaging in things that are a little bit riskier, this is why we have head injuries way more often in kids than we see adults. Next slide. So some of the common causes that we see at Penn State Hershey in our trauma program, definitely falls. It is our #1 mechanism of trauma here at Penn State Hershey Children's Hospital. And I will say any trauma center that you go to, falls is going to be the #1 mechanism. We drill down into that in kids to say, why do kids fall? For younger kids, sometimes it's developmental. Toddlers are going to toddle. Preschoolers are playing on playground equipment, things like that. Once they get older, they start saying things like, hey, mom, watch this. That always gives me a little bit of heartburn because it's usually precipitated by someone standing or climbing on something maybe they shouldn't. But we do see quite a lot of falls, even out of windows. Every single spring, we see kids who fall out of windows because they have screens and they push against the screens. They fall out of the screens. They fall off the monkey bars. They fall off any kind of equipment like that. We definitely see falls. Other sources of head injuries, sports injuries, we definitely see that, whether it's soccer, as depicted here in this photo, baseball. We had a pretty bad head injury earlier this spring. There was a kid, I want to say he was 13 or so, just kind of playing, practicing baseball. They were batting, not an official practice, but just a pickup sort of practice. He didn't have a helmet on and he got beamed really hard on his head because he wasn't wearing a protective helmet. Collisions on the playground, definitely motor vehicle accidents. We see a fair amount of those here. Assault or abuse, unhelmeted bicycle rider, and I would just say even unhelmeted any type of wheeled activities, whether it's a hoverboard or roller skates or ice. I guess people don't wear helmets on ice skating, but I kind of wish they would. Any of those activities where you're unhelmeted, you can have those kinds of risk factors. So that's sort of the introduction to what is a concussion or a mild TBI. Why do we care about it in children and pediatrics? How are they going to get it? And now I'm going to turn it over to Nikki, and she's going to talk to you about once you have it, now what?
So basically what I want to cover is, now that we've discussed what a TBI is, a mild TBI, and how the children can get those type of things, we want to kind of think about, so what would you do if a child presents to you, to your office, or you're called to an incident in which a child needs to be evaluated for a possible head injury? So what are the first steps that you're taking to evaluate this child? The biggest thing we want to do is decide, do they need immediate emergency care, or do you have time to assess the child a little bit further? So you're going to evaluate their mental status. Are they oriented? Are they awake? Are they looking at you? Are they able to converse with you? I often in the emergency department try to evaluate younger kids. You would ask older kids like an orientation question. What's your name? What's your birthday? Where are you? Who's the president? I used to say all the time, I joke about this now because kids don't really understand. I used to say, who lives in a pineapple under the sea? And kids would say SpongeBob. But now kids don't watch that show anymore. So that's not a good way to evaluate, but you need to evaluate that child based on their level of cognition. And then also if it's safe to get the child up and allow them to ambulate, are they balanced? Are they leaning to one side versus the other? Doing strengths. A lot of times I have kids squeeze my hands, pull me towards you, push me away. And then the same type of things with their legs. Push your feet down like you're driving a car, pull your toes to your nose. Are those strengths there? Are they equal? Is there an absence in one side versus the other? Assessing their scalp for any kind of skull abnormalities. So feeling their head where they were hit. Is there a big bump there? Is there an indent or depression? If you're seeing any deteriorating neurologic function, then obviously that's something that you're going to start thinking about, those big scary things like brain bleeds and skull fractures. Next slide, please. So here are some of the symptoms of concussion. So as Jen talked about, a mild TBI kind of encompasses a lot of different symptoms because you're affecting all different parts of your brain. So there's a lot of different symptoms that a kid could exhibit in a concussion. And it doesn't necessarily mean something big, bad, and scary, but there are things that you might see and you want to evaluate to see if those things are getting worse or if they're affecting that person's ability to mentate. So those symptoms would include headache, pressure in your head, issues with balance, like I stated before, any kind of dizziness, sensitivity to light or noise, difficulty paying attention. We see that a lot. Confusion, sleep issues, changes in their behavior. A big thing you see a lot of times when kids hit their head is nausea and vomiting. Obviously, a big concern would be if someone continues to vomit, but a lot of times kids will throw up that first initial impact. And that is a big sign of concussion. They have double or blurred vision, fatigue, they're groggy or dazed, have memory issues. They're slow to understand or respond, like Jen was saying about her son, just kind of staring off into space. Anything that you're noticing in their mood or irritability, and that kind of goes a little bit more towards younger kids. We see that a lot in babies, like inconsolable crying, or any changes in their personality. Again, if you're striking that frontal lobe, you can have big changes in personality. Next slide, please. So what are the big scary things that we're looking for? When you first get to that child and you're evaluating them, what are things that are making you think like, I need to get this person to the emergency department or they need further care? This area of loss of consciousness is kind of vague, but if there is at any point a loss of consciousness greater than 30 seconds, someone should be evaluated. You can see that in kids that don't have too terrible of concussions in the end once they're fully evaluated. But that is something that is concerning. It's something that we monitor. If they have a loss of consciousness, that can change their trauma criteria. Anything with increasing in their headache, the headache is getting really severe. And again, when I said with the vomiting, repeated vomiting, difficulty with their speech, confusion, pupillary changes, if you're able to assess their pupils, obviously if you can't wake them up, any behavioral changes, agitation, restlessness. If a child has a seizure after striking their head, then they should be evaluated. Sometimes, again, we see that and kids are totally fine in the end, but it's definitely something we want them to be checked out for. If you notice any weakness or numbness of the upper and lower extremities. So when I did say about the strengths, the grip and the pushing and pulling away, I also often just like do a quick touch the sides of their face, touch their hand, their arms and their legs. Does it feel the same on both sides? And then obviously if a kid is struck and has that motion of their neck going back, or they've actually hit their head on the ground and have anything with their cervical spine, if they have any tenderness or loss of range of motion in their neck, then we would want them to be evaluated emergently. Next slide, please. So basically what are we getting at? We want to know, does this kid need to go to the emergency department right now? Or is this something that you can monitor? You can send the kid home or monitor them in your office and see how their symptoms progress. So what makes us think of big, bad, scary things and what doesn't? Next slide, please. So if the patient is non-emergent, so you've determined that the kid is able to mentate, he's able to tell you where they are, their name, they don't have any of those big, scary symptoms that we discussed. Like, what are you going to do with now this concussed kid in your office? So we just say to monitor the symptoms closely, because the symptoms after you strike your head could present hours or even days after their injury. So we have this really great instructions that we give to patients, and I think it's really super helpful. It's on the CDC's website, and it kind of gives you like a step-by-step what to look for, things that are common and things that are not common, things that should be evaluated emergently, things that you should follow your PCP with. I think it's really helpful. I didn't attach it, but I do have the link there if you guys want to check that out. I think that's really helpful to give to parents and to kids to know what to expect when they go home, and something else to like refer to when they're coming into your office frequently after they've had a concussion. Next slide, please. So say you think they need an emergent evaluation and they have those big scary symptoms, or something just doesn't feel right in your gut and you want this kid evaluated. You send them to emergency department. A lot of times people say, well, why didn't they just do a CAT scan? Why didn't they just CAT scan your head? Well, there's a lot of risk in doing a CAT scan that people don't generally think about. So we use this PCARN criteria. It is the Pediatric Emergency Care Applied Research Network, which doesn't really pertain to the whole thing, but they set these guidelines that help us utilize this grid to decide whether or not we're going to give the child that much radiation exposure. So you can see at the top there, if they're younger than 2 years old and they have a change in mental status, or their GCS is less than 15, or they have a palpable skull fracture, like I said, when you're evaluating that scalp, then a head CT is recommended if you have any of those symptoms. If you don't have those symptoms, then we go to the second area, which gives us a little bit more information. Have they had a loss of consciousness that's greater than 5 seconds, non-frontal hematoma or not acting normally, or they have a severe mechanism of injury? Then that kind of is left to the provider's discretion. We can observe them, or we could do a head CT. You have none of those things and it says discharge, which why would they be there if they had those things? If they're older than 2 years old, then we look for altered mental status, a GCS less than 15, or signs of a basilar skull fracture. That would be like battle signs, bruising underneath of your eyes, bleeding from the ears and nose, or sometimes you could have cerebral spinal fluid coming from your nose, so running from your nose or your ears, clear fluids. We would recommend a head CT. And again, we go in that yellow area where we can have that history of a loss of consciousness, vomiting, severe headache, or a severe mechanism. Then we would say, do we want to observe them or do we want to do a head CT? So go ahead.
No, just real quick, in the chat, hello. There was a question in the chat about what are the risks of CT, and I'm glad you asked, because the risks of a head CT, when you're having a developing brain, your risk of developing cancer is so much higher. So radiation exposure to children exponentially increases their risk of cancer. The DNA in the cells, they're friable and they're more susceptible to that radiation, putting them at risk of cancer. It's very different than adults. So when you're a kid, we don't CAT scan kids willy-nilly. It's got to be a risk versus benefit. So if we are absolutely concerned that they have a skull fracture or brain bleed that could require serious intervention, the risk of the CT is worth the benefit. But if you have a kid who, even if they blacked out, lost consciousness, vomiting, but now is looking okay, we're really going to follow PCARN and see, do we have to CAT scan? Because every single time a kid has a CAT scan and is exposed to radiation, that has just increased their chance they are going to get cancer later in life. So we really try hard to not scan them if they don't need to be scanned. Sorry.
No, that's perfect. Thank you. So if there's no CAT scan indicated, or we have done the CAT scan, we've decided that the benefit outweighs the risk, and the scan is negative, then we will observe the patient in the emergency department for 4 hours. We have specific discharge criteria that has to be met within that 4-hour time frame. If the child doesn't meet all those bullet points, then they will be admitted to inpatient. Next slide. I'll explain those things. So the discharge criteria just basically means you have to look like a peach. You got to be doing all the normal things that a kid's doing, despite that initial injury and the symptoms you might have initially had, or even precipitated us getting a CAT scan. If you are at that 4-hour mark, having not had any other complications, so you are totally with it, alert oriented, there's no changes in developmental skills, they're able to walk, we ambulate them, make sure they have a steady gait, there's no ataxias or dizziness, you're tolerating oral intake without any vomiting, their headache is an acceptable level, so they can still have a headache, but we just want to make sure that it's something that they can tolerate, or that headache is being affected by medication. So if we're giving you Tylenol or Motrin, that's helping that headache go down enough that you can tolerate it. Any mood stability, so like with younger kids, we want to make sure that they're not super fussy, and they're able to stay awake and interact. If they meet that criteria, then they can go home. And then that's kind of where they end up going back into school, and they are being monitored at home for any further complications from that concussion. And again, like we said, that could take a long time for that person to recover. They could have reinitiation of those symptoms. The headache could get worse. They could have different things that could pop up later on. But this is just saying to us that they're stable enough to go home at that time, and that we don't need to CAT scan them. That might be something else. If you're in that yellow area on that P card, and then you start to not be able to do these things, then we might revisit that idea that we might need to do a CAT scan. Next slide, please. So if you don't meet that criteria, they're still vomiting, they still have a headache, they have mood changes, also difficult at nighttime because kids get tired, and then we're like, oh, are you sleepier because it's bedtime, or are you sleepier because of your head injury? So it kind of becomes a gray area. But if in that 4-hour time frame things don't look perfect, we're going to talk about admitting you to the hospital. And we have a pretty standard policy that we uphold for moderate or mild traumatic brain injuries. And these are the things that we would do if they were admitted inpatient. To admit them for observation, meaning we would keep them overnight and reevaluate in the morning. They would get IV fluids to make sure they were fully hydrated, make sure that helps them also with their headache. This is a difficult one because a lot of kids don't want to do this. So we don't want to turn their TV on full blast or let them use their iPads or their cell phones. We want to try to decrease all that stimulation and allow them to have that time to recover so that they're fully ready to go home. We consult physical therapy to make sure that they're not having any vestibular abnormalities. If they never had that, they probably won't need to get a physical therapy consult. Just if they're doing well with their steady gait, then they don't usually get that. If they have risk factors for prolonged recovery, which I think is a couple slides ahead here, or maybe the next one. I think it's the next one. We'll discuss that. If they have that, then we have a physical medicine and rehab. These doctors are amazing. They are really, really smart people, and we consult them, and they help us determine what factors would make this child have a prolonged recovery and ways that they can help them. They have a specialized concussion clinic in which they follow up with these patients, and they do like very intense deciding on like how frequent the kids will come and see them. And they're just really wonderful people. I'm a big fan, if you can't tell. And then we do neurologic exams frequently while they're in the hospital and on that overnight period. And the frequency is determined by the physician's order. Next slide, please. Can we do it ourselves? So the risk factors of prolonged recovery are a history of prior concussion, like Jen discussed earlier. That repeated concussions can cause it to be even longer for that child to recover from that concussion. And in particular, if they haven't even fully recovered and have an additional injury, that can just really prolong things and cause a lot of symptoms for kids. If they have a history of headaches, so kids that have histories of headaches or migraines, and then they get a concussion, they have a significant risk for having a prolonged recovery. Developmental history or learning disabilities, behavioral concerns in ADHD kids. Any kid with ADHD and autism that gets a concussion, we immediately consult the behavioral, not the behavioral, physical PMNR. If you have a psychiatric history of anxiety, depression, or sleep disorders, that can also be really exacerbated by concussions as well.
I think in the notion of like, what is a prolonged recovery? And I can't remember if we talked about time frame for concussion. Some kids do better in just a couple days. Some takes weeks and weeks and weeks and weeks. I talked about my kid who had a pretty bad concussion. He didn't have any of these. He had no risk factors for prolonged recovery. And it was still a week and a half at least of really having a lot of delays in connecting things, very irritable, a lot of symptoms. And so kids who have these, I mean, you're talking several weeks of symptoms where it's going to be very difficult for them to learn, for them to be in environments that are stimulating, to be around other kids. So it's good to be aware of kids who have these risk factors and what that recovery could look like.
Oh, next slide.
Next slide.
And this is kind of what Jen was just kind of talking about. So things that we just try to think about with kids integrating back into school after they've had an injury. They might just feel frustrated that they can't get back to their normal activity. They're not able to go back to playing football or whatever they do to get their outlet, ways that they can interact with other kids. They're just feeling frustrated that they're not back at their baseline, sad or angry, or they cannot return to school right away or resume their normal activities. They may also feel overwhelmed as they reintegrate back into their daily life. It's just, I mean, sometimes daily life can just be overwhelming all in itself. A classroom full of kids or a bus full of kids yelling. If you already have a brain injury and you're trying to recover from that and all of that stimulation happening, a lot of times we resort to electronics for a lot of different things nowadays, using computers in class or pads. All of that is going to exacerbate those symptoms for those kids. And like Jen said, that most kids will recover in about 4 weeks, but that's a pretty not really set time frame. You know, some kids will recover really earlier on, and other kids it'll take even longer depending on their risk factors and the different stimulus that they have when they're in school. So things that we can do while they're in school, they can sit where they can focus in the front of the class or a spot that minimizes distraction. We could write down what they need to remember because their memory might not be back to normal. So kind of give them a list of to-do things. Ask to record a lesson if possible so that they could look back on things and see if there's anything that they missed. And then the big thing that we always try to reinforce is taking breaks anytime that they have symptoms. I'm going to soon discuss this set thing that we send kids back to school with. It's a return to school note that kind of gives like pretty specifics for that child, the different times that we should allow them to have rest. And the biggest thing is if a kid is having symptoms. So if they're sitting in class and then they start to have a headache, they should stop what they're doing. What they're doing is causing their brain injury to react and making it worse. It's not allowing them the time to rest. So if they're having any of those symptoms, they're feeling nauseous, the light is bothering them, then those type of things, then they should withdraw from whatever activity they're doing at that time and take a break. And we should be slowly integrating them back into school. We're not just going to say, hey, you went to the ER, they said you were fine, you're going back to school full time the next day.
I'm glad you mentioned memory because I do think this is one of the things that for kids is hard because whether you're a parent, whether you're a teacher, whether you're a school nurse, when you have a kid who's recovering from a concussion, and if you tell that kid something and they forget it a few minutes later and ask the same question, it can be tempting for caregivers to get frustrated. We hear parents who get frustrated. I already told you this, but these kids, they can't retain it. And so I think explaining to teachers, explaining to people in this school that these children are going to have a hard time with memory for a few weeks and to be very forgiving of that. And to expect that when you tell them something, they may not be able to retain it the same as normal, and written instructions are much better. So if you have the option of telling them to do something versus telling them and providing them with something written, that would be better. Next slide.
The demands that are placed on our kids in schools these days are pretty high. And most kids really work hard to try to meet those demands. And so they're trying to please the teachers. They're already achievement oriented. They are actually doing things that are then affecting their recovery, which then long term delays it, which then continues to affect their learning. So it's a sort of a negative cycle. So one of the big areas that we focus on with kids clinically is what's the best ways to help them return to school. How do we go about really helping the school to understand the nature of this injury for that youngster, and how do you build the right kind of supports in there so that the youngster's recovery is guided properly. And we try to understand how long can they go in a classroom before those symptoms begin to worsen, because it's the worsening of those symptoms that tell us that brain's metabolic activity is basically being overrun. It's gone beyond its limits and we need to stop. And so by teaching the student to monitor those symptoms, by educating the teacher to be aware of that, the two can really work together to really give that sort of optimal time that is effective for the student to be in class. Because the bottom line is, when they are that symptomatic in class, they're not learning.
I really like that part in the video where he says if they're having symptoms, then they're not learning. So that's, I mean, that's the whole point of them going to school, is to learn. So if they're not getting anything from it and it's just causing them more frustration, causing them more symptoms, that's not what any of our goal is in that situation. So when we discharge a kid from the hospital, we actually have a academic liaison and myself, and we work on these pretty extensive, what we call school notes. So this is basically returning to school after you've had a concussion or a traumatic brain injury. We do these even for kids who have significantly brain injuries with like brain bleeds and skull fractures and stuff like that. This one, I think, is more for concussion and mild traumatic brain injury, which is what we're discussing in this. And the biggest thing is setting the expectations from the beginning is going to give a kid the best chance to recover and do the best they can while they're at school. So we kind of set the bar of what to expect. And then usually these kids will follow up in that concussion clinic. And then they'll start to change the things based on the kid's symptoms. So like we might say a kid will go back to school for half of the day for this many days, and then they'll come to concussion clinic and determine if they're still having enough symptoms. We'll keep them a half a day, or we'll then advance them to once a day or a full day. So this first page just basically kind of lets everybody know that like that this is a big deal. Like what happened to this child's brain is a big deal, and these are the things that we can do to try and help them better integrate back into school. So the student may return to school while the nurse, you or the teachers, closely monitor the student. So teachers should observe and frequently check on the student. Just because the child looks okay doesn't mean they're not experiencing symptoms. So we should be asking them, are you feeling okay? Are you having a headache? Does anything bother you at this point? To see if we need to remove them from that situation, give them some rest, or if they're ready to continue in the school. Next slide, please. And this is that initial part that I was talking about. So they can return to school on this date, and they're going to go for full day, or they're going to go for a half day. And then we always remind people to not like have those kids make up that work that they've missed. That's just going to make things worse. That's going to exacerbate symptoms. It's going to frustrate them. It's going to make them feel like they can't catch up. And then they're not going to have that time that they need for recovery. I get that they need to learn the things that they need to learn, but like giving a kid a bunch of work that they missed while they were out is not helpful. So it always just says at the bottom, the student cannot carry a double workload or new makeup work. So this is the physical activity. Kids hate this part. So we say that they most of the time initially cannot participate in gym class, sports, or outside recess. Anything where they're going to put themselves at risk of getting struck in the head again, or, moving their body too fast in one way to cause their brain more injury. And they really hate this part because we tell them that they can't go to gym class and they instead need to rest. And so they just feel like they're missing out on things, but that's really what their brain needs. And we also encourage them not to take them out of a physical activity and instead give them some kind of academic thing to work on, because that's not helpful either. Should not participate or be in close proximity of any activities that place a student at risk. So letting them sit on the sidelines while kids are playing dodgeball is probably not the best decision either. And then not to return to sports or practices or weightlifting or strenuous activity until a physician follow-up. So again, that usually happens either at their PCP or at that concussion clinic. And then older kids, we always tell them you can't drive. They love that too. And you can't return to play if you ever have any symptoms. So this part kind of goes through the different breaks that we encourage. So resting is critical because it helps the brain to heal. So mental and cognitive exertion requires the brain to use energy. And after injury, the brain's energy is already depleted. And when combined with thinking, the symptoms may worsen, which is what we were discussing before. So we kind of mark it out. It's very individualized. This is kind of a generic part of that form because it's really, we try to individualize it for each kid. But short breaks within the classroom, 5 to 10 minutes every hour where they have a break and are able to go someplace where they're not stimulated. Allow the student to go to the nurse's office to rest if their symptoms are increasing, and they may need multiple visits within one day. And then we schedule rest breaks, so 15 to 20 minutes in a quiet location, one mid-morning and one mid-afternoon, and that may reduce the breaks as the symptoms improve. So this one's kind of hard to accommodate, but we try to decrease the noise or visual stimulation. So consider having lunch in a quiet area with a friend for just a few days. Kids don't like that either. They don't want to miss out on spending time with their friends, but in a large cafeteria with lots of noise and stimulation and lights and things going around, that's not going to help somebody recover. And again, with the screens, the screen time, the computer time, being on their phones, all that kind of stuff is not helpful for the brain to recover either. So we always encourage them to sit away from bright screens or lowering the shades in the room if they can, to see if their symptoms will improve. So when we talk about returning to sports, they can only return to sports with the approval of a healthcare provider. Usually they follow up with a concussion clinic. We have specialists that do sports concussion here at Penn State Hershey. So they can be a little bit more specific about when kids can go back to play. But it's always a big thing. If a kid is having symptoms, they cannot return to play. That is not a good process at all. That is, the brain is telling you, like, I'm not ready. I'm not ready to get back out there, and I definitely don't want to get hit in the head again. So it's a gradual process. And again, this is another thing that kids get frustrated with because they want to get back to that. That's what makes them, feel like they're integrated in their world. They're doing the things that they like to do. So we just try to encourage them to do slow integration back into physical activity. So do light aerobic activity, 5 to 10 minutes of walking or an exercise bike. Moderate activity, you can begin to participate in activities that increase your heart rate. And the way that we judge this is we allow them to do those things. And then if they don't have any symptoms, you can move on to the next step. So that if you're not having any symptoms doing that light aerobic activity, then you can try the moderate activity. And if at any point you get symptoms, you kind of have to back it back down. And then kind of progress as things go along with their symptoms. And practice in full contact can begin with a controlled setting and close monitoring initially.
Okay, so now let's kind of close the loop full circle and talk about how we can prevent these in the first place. Because truly, injury prevention is a lot of what we do here in trauma. We take care of injuries, but we also try to teach our community how not to have them, especially because I think concussion is really hard in today's world. I mean, when I grew up, we didn't have screens, and now screens and electronics and technology, it's so embedded in everything we do. And so even in the world of concussion research and experts in concussion, I think some of the greatest minds are trying to put together, how do we deal with this when we know our landscape and our world is meant to be electronic these days, but that actually worsens concussion. So prevention is also a big part of it. So hopefully we never get there. So some things about prevention. Definitely sports. This is very much across the board with a lot of kids. Football is one of the most high impact sports for sure. And there are some good steps to prevent injury. Always wear protective equipment. The fit of your equipment should be proper, should be in good working condition. One of the things that we see with protective equipment, kids are good at wearing it at formal practices and at games, but when kids are playing in their neighborhood, in their backyard, they're not wearing equipment. I was just in my neighborhood recently and there were a bunch of kids playing. Not any of them had on protective equipment in the neighborhood. My neighbors loved me because I did go out there and say, hey, where are your things? Because those injuries still happen. They're practicing, they're having contact. Those things are important. So definitely those unofficial sort of pickup games, equipment is still needed there. With football, teaching a good tackling technique. I'm sure sports coaches are trained on how to do that. Avoiding unnecessary helmet to helmet contact. And the biggest thing is if a player gets a head injury, they have to be removed from play until they've been cleared by a healthcare professional. The moral of the story is, if in doubt, sit it out. And one of the things is really teaching kids to speak up and to let someone know that they hit their head, they're having a headache, they've had impact. Sometimes, especially kids who don't want to be pulled from a game, they may not want to speak up, but we have to educate them the importance of why we speak up, because we care about their safety and we would much rather have them be able to play the whole season than stay in a game with a head injury, get another head injury, and now they haven't just missed a game, they've missed their whole season. So sometimes that can be impactful for kids to hear that. We are seeing some head injuries rising in soccer. The U.S. soccer organization put out some new guidelines that kids under the age of 10 should not head the ball. And then ages 11 to 13, it's limited to practice only. Baseball, definitely always wearing a helmet for batting at all times, even in unofficial practices, pickup games, neighborhood games, all that kind of stuff. Next slide. More on injury prevention. So bicycle riders, children and adults, and I say adults because we really need to be the example. A lot of times adults, I see them riding with their kids. The kid has a helmet, the adult doesn't. And that doesn't set a very good example. So we need to make sure that we're all wearing helmets. Helmets should be fitted properly and for all wheeled activities. We've got rollerblades, we have roller skates, we have hoverboards, we have scooters, anything that you're on wheels, you really should have a helmet to protect your head. Car seats and booster seats, making sure they're the right fit, the right size, and kids are in the correct seat. Some supervision on playgrounds and discouraging risky activities. I think this is where it can be difficult because from a parent perspective, we don't want to be helicopter parents. We don't want to be on top of our kids all the time. We want to give them some autonomy. But at the same time, one of the things we see in our hospital, we see a lot of injuries with distracted parents. So kids are engaging in risk-taking activities and the parents are on their phone. They're checked out. And while we don't necessarily want parents right on top of their kids every step of the way, you still have to oversee them to make sure that what they're engaging in is appropriate activity. So whether that's a parent, whether that's a school staff member who's overseeing what happens on the playground and making sure that we're being careful not to engage in those risky activities. Home safety is a big thing that we talk about. Making sure those window guards are installed. We talked about kids who fall out of screen windows. Literally, we see it every single spring. As soon as April hits on a nice day in our trauma program, where we say, okay, here comes the fall from the windows, it happens every single year. Keeping your hallways and stairs free of clutter. Definitely securing TV and furniture. We do see tip over injuries quite a bit with heavier furniture. Kids either try to climb on bookshelves or things like that, and those things can fall over and fall on top of the kids, and that creates injuries as well. So those are some things to keep in mind. And I think that kind of wraps it up from the injury perspective page. The next page is our references and our thank you. So that gives us about 10 minutes. If you have any questions, any comments, things you want to hear about, we would love to answer those for you.
Great. Well, thank you so much, Nikki and Jen, and I will give it a few minutes in case anyone wants to put any comments or questions. It looks like we had one person perhaps raise their hand. I'm not sure if we're able to unmute individuals. It looks like we can. So Marie Shavlin, would you like to ask your question?
Yes, hi, ladies. I'm sorry, I got in a few minutes late, so I'm not sure if you addressed this at the beginning, but it's a question that I've been asked through the years. There's so many pre-concussion assessments that are offered to parents to get a baseline on their kids' brain function before they go into sports. You know, what is your professional recommendation on that? Do you find it helpful? Do you see a frequency, a good use of those screenings? Can you address that at all? Because it's a question that parents ask our opinion about getting locally here often.
I think what's helpful, so we don't have one particular like pre-concussion screening tool per se that we use. What I find very valuable about getting a baseline is if there is going to be prolonged recovery if there is an injury. So a child who has no history of ADHD, no prior headaches, no concussion, no history of migraines, none of those things, they're going to experience a recovery after a head injury that is very different than a child who has those things. And so I think it's really important that you know what the baseline is, because then you can anticipate, one, hopefully they won't get injured, but two, it gives you some better appreciation for being safe in sports, making sure that you're really being careful. Not that you shouldn't be careful all around, but definitely when it comes to that extended recovery, and then you have that baseline that you're comparing it to, especially with kids with ADHD. We see some of those kids with ADHD and concussions getting very difficult in terms of paying attention, being able to process material, not getting irritable. It's tough. And so having that baseline can be helpful. We don't have one particular one that we use though. And I also see in the chat, what's your thought on treating headache pain? I mean, to me, definitely hands down, treat the headache pain. Kids who are miserable and uncomfortable, it is not going to help them at all to be feeling that way. So Tylenol, Motrin, things that they need to feel better, that's great. Sometimes I hear people say, well, we don't want to give them treatment because what if it masks their symptoms? Well, what symptoms are we looking for? So you remember that slide when we talked about those big, scary symptoms, right? So if you have a kid that you can't wake up, they're repeatedly vomiting, they can't stop, they're not themselves, they're having seizures, Tylenol and Motrin is not going to mask that, not going to help that. But those kids who are really struggling with it, definitely it's going to benefit them. I do think that being aware of dosages is very important. You can overdose kids on Tylenol. So medication should always be given as directed. Making sure to have a little food in their belly, especially with the ibuprofen, that can be tough on the belly. But yeah, we recommend before the school day, if you have a kid who's just having recurrent headaches, there is nothing wrong at all with giving some Tylenol and Motrin and being proactive about it. We have some parents that before they go to school, they get Tylenol and Motrin for a few days as they're riding out some of those symptoms. Anything you wanted to add, Nikki?
I was just going to say, medicating is good to help treat that pain. And I don't think you would be masking anything. That the brain is telling you when they have that headache, if they have that concussion, that it's overstimulated, right? So you could medicate the child, but then also take them away from that and allow them to have that rest period, and then see if the medication and the rest helps that headache that they have as a symptom.
Other questions? We had a kid who sticks with me that we had, gosh, I think it was in February. And this is a kid who was 8 years old and was a pedestrian who was struck by a car. Thankfully didn't have major brain injury, had a broken bone, but hit his head pretty hard and was really concussed. We followed him for quite a long time and gave some updates on the EMS companies for him, but concussion was the symptom that unexpectedly he dealt with the most. We thought the broken bones and all of those things would be the biggest source of the follow-up, but what really kept him from getting back to normal at school was his concussion. He had a history of ADHD, he had migraines, things like that. His recovery, I want to say it was like 6 weeks of him not being able to get back to school. And he got so frustrated the way that this was progressing, couldn't do sports, and he didn't have an outlet. So for a kid who has ADHD, who their outlet is physical activity to go burn off those feelings, there's nowhere to put that sometimes. And that's hard. So we talked with the family about taking walks, at least getting outside, doing things that are safe, that's not maybe running. We have a 2 feet on the ground rule, or at least 1 foot on the ground. So jogging and running was too early for that, but could take some walks around the neighborhood. But it really impressed upon me how people say just a concussion, quote unquote. This kid got hit by a car, had broken bones, but it was the concussion that really, really took a while to recover when he got back to school. Other questions or thoughts? Well, we appreciate all of your attention. I think our contact information, Angela and Katie can share. Feel free to reach out to us anytime. Nikki is a wealth of knowledge about school follow-up. She is frequently interacting with our academic liaison, and we are trying to find more ways to bridge our gap from hospital to school. So we're an open book. Reach out.
Definitely.
Wonderful. Thank you again so much, Nikki and Jen. Wonderful presentation, a lot of great information that we hope that you as school nurses can take back with you and to really just help integrate these students back into the learning environment at schools.